Good evening, everyone. Good evening. Good evening. Welcome. I love the energy in the room. I'm pleased to see that many of you have reconnected with old friends and are making new ones. But please do take your seat if you would like to get one. There's still a few up here. I'm going to get started. My name is Raj Kumar. I'm the president and editor-in-chief of DevEx. I am delighted to be with all of you. I know this is a room full of people who are committed to the issues we are here to discuss. Universal health coverage, cancer, inequity in the world. We are committed to those issues. I hear a bit of music. Maybe we can turn that down. I don't mind having background music, but might help. On behalf of Roche and Weber Shandwick, I am delighted to welcome all of you. You know, this week, UN General Assembly Week is always crazy. I think every year it gets a little bit more intense. And I have had even people like some of the ones who are going to be on this panel in a moment who are veterans of this week and of these issues say to me, why do we do this again? Why do we go stand in those long security lines and try to make it from one event to the next? And well, there's a good reason, I think, because actually this week does set the agenda for much that happens on many issues, but in particular around issues of health. And in fact, it was because of the UN General Assembly that many of us are here with our Sustainable Development Goal pins. Others are here with their umbrella pins. It is because of this week, with all its chaos and all its craziness, that actually important global issues make their way onto an agenda and end up getting funded and making real progress, even on the very local level all over the world. So for that reason, we thought it was important to have a day, an event, where we all get together and talk about where do we stand on UHC and where do we stand on cancer in particular. This is a disease that for many years was really not on the global agenda. We did not think of it when we thought about lower and middle income countries. It was not considered a priority. This past year, there were around 10 million deaths from cancer in the world. It ought to be a priority. And this event is all about making sure that it is one. So we've got an incredible group together who will help us make that point. And I just want to underline for you one little thing that you hear sometimes from Warren Buffett, which I love to think about. He talks about the ovarian lottery. Is anybody familiar with this term from Warren Buffett, the investor? He says basically the biggest lottery in the world is where you're born. Right? So one thing none of us can control, where you're born. And if you think about the vast disparities across many issues, but in particular for the one we're here to talk about today around cancer, it matters a lot where in the world you are born, whether you're diagnosed and whether you're treated. So we're here to talk today about, can we address that? Can we change those realities in the world? And there's nobody better to get us started than the president of the Union for International Cancer Control, UICC, Her Royal Highness, Princess Dina Mired. Please join me in welcoming her. So you and I have done this before.
I know, we did, but these are better chairs.
And yes, last time we were sliding right off.
We really were. We had to use a lot of our, core muscles to stay on our chair.
This time, if we do, there are real consequences. It's a longer fall. So, but it's great to be back with you again.
Yeah.
When I first spoke with you, you were just starting out in this role as president of UICC.
Yes.
And you've been there now, and I think are really shaking up the conversation. So I want to start with you. Why do we think about UHC and cancer as related points? Why does this matter? Frame it for us, please.
Yes. Thank you, Raj. I think the best way to really understand the value of UHC is when you really imagine when you don't have one.
Yeah.
That's the thing, when you don't have one. And certainly when I was the Director General at the King Hussein Cancer Foundation, starting out, a lot of people, nobody was covered for cancer. Nobody was. So in a way, there was no coverage. People literally, and I, bringing an example, some politician actually during this campaign said something, it's really difficult to hate up close and personal.
Yeah.
The same, it's really difficult to see someone who's looking for treatment up close and personal, and they say, and you are there standing there, and they're saying, I need to be treated, to treat my child for leukemia or whatever, and somebody has to say, look, I have the magic potion here, but not for you. it's really difficult. And we've seen that countless of, and luckily we tried to do something about it. The whole team in Jordan, we started to get donations exactly to cover people for treatment and so on. So, but we still had some people fall through the gaps. So why is UHC important? I see it in Jordan. For example, this whole rights of patients, whether you talk to a health minister and you say, do we have UHC in Jordan? He said, yes, of course we have. And it's, in some ways, it's true. But part of it, let's say for cancer in particular, some people are covered in the worst hospital ever, public hospital, that actually doesn't have oncologists. Right. Why would I want to be covered in a place that doesn't have quality cancer care, let alone quality cancer care? So they do cover people. And in Jordan, we have this thing that, everybody can find somebody to try to get what they want, but it's not a right. Right. It's not a given right.
You can network your way.
You network your way, and you will find somebody. I get so many calls from people, Princess Dina, can you call this place? My, son needs this treatment. It's costly. Can I go to this? Blah, blah, blah. So it's very much like that. So UHC, first of all, gives you that right and empowers people that, look, you have to pay money, but that's the thing. People have to understand it's not for free. You contribute a sum of money, like we've seen now many examples, but then you have to know what are your rights, what are you getting from those rights. So it's not that you have to network and it's like a gift from government. People have to understand it's their intrinsic right, and it has to be in the law clearly saying you are allowed and it is your right to have the chance to be treated qualitatively. Because I've said to the health minister many times, why is it you're still in, how can you put your head at night knowing you're sending people to this hospital? There's not one single oncologist. Why don't you just send them to the King Hussein, the same budget?
But what do you say?
So this is important.
What do you say when you get this pushback, which is the pushback maybe even supporters are thinking in the back of their mind? And we see this with many of the people who are part of our community at DevX who say, well, if I have $1 more to donate, I want to have the maximum impact, and that's going to go to bed nets, or it's going to go to vitamin A pills or deworming pills. And it sounds good to talk about UHC, but isn't there not enough money for this? And don't we really not know what to do if we suddenly got more money? What do you say to that?
I feel it goes even before that. Many of the capacities at our health ministry, certainly in Jordan and certainly in many developing countries, they don't have the capacity for a special team that actually has the time to strategize and think and have a fresh view. They don't have that. And when you read about, for example, the transformation in Turkey, I don't know if many of you read the article at The Lancet, how they did it. One of the things they did, they actually created, before they start, the right approach to do UHC. So what they did, they created a transformation team that actually has the time to sit and think and has a bird's eye view to look at where they are, what they need to change, and so on. I look back at our poor health minister in Jordan. He's so nice, lots of good ideas. He doesn't have the time to think. And all the people at the ministry, all they are doing is operations. So half the time, if they want to do something, they quickly say, oh, let's do a committee. After 2 weeks, we're going to change this big thing. Then everybody goes up in arms because it's not well thought out. It's not really logical or scientific. It's a quick fix. And then they actually reverse that action, and so on and so forth. So I want to say that UHC, when you want to start it, you need to also start the approach. You have to design how you're going to do it. And I think in Thailand, they did something called policy entrepreneurs. Again, this idea that you need somebody to change the way of how the ministry works, that you not just operation and tasks, you have to have that strategic team, and not only for a little bit, they have to stay at the same throughout the process. And also to have it, political will across the whole government. You don't want, I've seen 10 ministers change in 2 years. You can't have each plan, stuck to the political cycle of a health minister. It has to be really taken as a decision that it has to be continuous with all the others. Otherwise, it's not going to work.
And that's why UHC is such a benefit in a way, right?
Yes.
Because we get out of a world of thinking of this specific disease vertical, that specific
No.
disease vertical, and instead we're thinking of the system.
Yes, it's a systems approach. How to do it first, the government has to decide so they succeed. And also they have a lot to do with explaining to the people. How, they have to have buy-in on the grassroots as well. So they become also, in a way, enablers to the government. They could become also a pressure group to ask for more quality from services. They will become, in a way, you are empowering patients' rights. And people's rights also. They become your eye and ears also. When they do an improvement in a service or something, they also feed back into the system. And I think that's what successful countries have done, like Turkey, Thailand, and others, because they looked at it completely from the supply and demand side. And they really made amazing plans. If they, for example, and again, we go back to plans, cancer control plans, NCD plans, health plans. If you don't plan those things, you're going to fail, right? You plan to fail. So, and it's not always that money is not there. I know from my own example, there's so many inefficiencies, right? From my own example at KHCC, before the whole team helped to really make our center finally a great center. Before that, imagine, we had the building, the machinery. We even pride ourselves in Jordan to have top-notch nurses, doctors who are trained all over the world, etc. But we didn't get it together, until we fixed the governance and the managerial structure. But before that, I remember making a call to some really influential person because we wanted to bring a director from the NCI, to actually a Jordanian, to help jumpstart the process. And that person wanted a salary, a big salary for Jordan. And suddenly it stopped for that. And I said to them, for God's sake, we are spending millions sending to the Mayo Clinic, actually investing in other people, giving them cash up front, here and there, investing. We have this one person who's going to start to come, with the process and so on. Not even 100,000 a year or anything like. We're going to stop this because of this, but it's okay to spend the millions. And luckily, when everybody fought for this and so on, and everybody worked together, we saved the government millions of actually, treating not the few for the millions abroad, treating millions in our country, and much cheaper than they would be treated in the US.
I love that story because it really is about a mindset shift.
A mindset shift, yes.
And that's sometimes the hardest thing to do, is to change the way we all think about a problem.
Yes.
And in a moment when we have this panel, you're going to get to hear about how people are exactly making that mindset shift in many parts of the world. But I do want to ask you, because I've read that you've called NCDs serial killers.
Yes.
And I think that is part of this mindset shift, right? Because so many people in the global health community think of these NCDs as a problem that's someone else's, or it's too hard to tackle in many of these contexts, and you're reframing it totally. So how do you think, now that you've been on this journey for years, maybe you want to even say a word about why you started the hospital and what your personal situation was, how do you think we're doing? Where do you think we are?
Well, I think there has been a lot of progress. I mean, there has been. We can't say there hasn't, but is it enough? No, it's not enough. It's, it still needs more countries really take, we've done, like, as president of UICC, and of course UICC, joined with the NCD Alliance and others to do great things. So at least you put the conversation out there. Yeah. So in a way, our country, somebody sitting at the Ministry of Health started to hear about NCDs. So that's great. But to actually get it moving, to prevent tobacco, to actually make policies to prevent tobacco, which we are doing terribly in Jordan, I might add, with that, and so on, you really need political will. And I was very happy today, by the way, how Dr. Tedros framed it. He said, UHC is a political issue. It's not just a moral issue, it's a political issue. And politicians need to make that choice. And many presidents in the room actually put their hand up, said, I made that political choice. And they already started to see, wins along the way. Since the conversation in 2011, you've had more countries doing cancer plans. You've had more countries doing cancer registries. Is it enough? Have they all started to implement those plans? I don't know. That's where the political will kicks in. But I just want to pick up on something you've just said, which is the idea, very important to look at universal health coverage as a transformation approach. Many of our countries, have long been geared to communicable diseases. And certainly in Jordan, we've had so many shocks with so many refugees and so on. So the system is almost breaking at the seams. It's no good. Like when you have a house and you keep adding things, there is a point that comes, you say, you know what, let's demolish the house and start again. It's cheaper. And I think you need to have that approach, to have a fresh view at the system, throw everything that was and think again. Why should, to stop all this designing of vertical diseases. You think of the patient, think again of the patient as a whole human being, not with body parts, as Princess Nono says from WHO. And really say, and really we need to go back on strengthening primary health care to do many things that, they haven't been trained to take up as well. So that when a woman goes to the primary health care, she can be asked about when is her next early detection for breast cancer? Did she do her pap smear? Did she do one-stop shop? Not everything is, because everything else has been geared to communicable.
Yeah.
This is not talk about or stop smoking or whatever, health information that needs to happen.
Yeah, UHC is in many ways a truly radical idea. I'm not sure it's always positioned and understood that way, but it's a really radical idea. We're often in rooms like this that we don't look like revolutionaries, but this is a radical revolutionary idea. I do want to get our panel up here to continue that discussion, talk about why. Please, your way up if you can. And any which way you like. Yes, please. Please join us, Kitinji. I'm going to start with Dr. Kitinji Gitahi because my good friend from Nairobi is with us, the CEO of AMREF Worldwide, but unfortunately he is not with us for long. He has got to run. So I actually have a new book out called The Business of Changing the World, and I quote this gentleman in the book about UHC. In it, he says, we don't do UHC because we are rich. We do UHC because we are poor, right? That this is actually a transformative way. And so maybe you can just kick off on that point. Explain to us how you see UHC in your context. We have much of the world represented on this panel. In your context, where do you see it? And how does it relate to the issue of cancer that we're here to talk about?
Can we first give a sitting ovation to the fact that we have a UHC declaration today?
Sure.
It's fantastic. We never thought we'd be here, and now we are. Actually, for many of you who may have followed the journey, we had many times we thought there would be no declaration today, actually. Up to about 2 weeks ago, we thought there would be no declaration. Because there were disagreements about women's rights. There were disagreements about migrants. But now we have it. So fantastic, and thank you for, revisiting that issue. That's actually a political choice. I think that's one major win that we have to celebrate, despite the fact that there are many challenges coming along the way. But this political declaration just gives us kind of the goal, as Takemi, who is now the WHO ambassador for for UHC, said. UHC is our own target, but the goal is a healthy community. That's the goal. So UHC is really our own target of this is where we want to reach. But if you reach 100% coverage, but you don't offer better health, you don't offer people good health, then you have not achieved, the goal. The goal is not just to achieve UHC. And along that journey, and I discovered that you can know where you want to go, but not get there. I actually got lost coming here for 20 minutes and had to ask for help. So we know exactly where we want to go, but getting there can be very difficult. And that's the real challenge that we are going to find. As we wake up tomorrow, we have a declaration in our hands. The journey from there to getting where we want to go is treacherous. It's actually very difficult. And I think we have seen many countries struggle with it. And the challenges are many. The challenges have to do first with the political choice. So today we hope that because the president has made a political choice, that box is ticked. But when they go back, they'll go back and do politics. That's what we expect. They'll go back to their parties and talk about the next election. So somebody has to do the job. And I think the people who have to do the job is ourselves. It's not the Ministry of Health, it's all of us here who are seated here who have to do the job. And the question is, how do we do the job within the constraints that we have? In many of the countries that we are talking about that don't have UHC, we saw in the Global Monitoring Report that was released by WHO, many of you may have been there when we were launching it, that coverage has dramatically increased, significantly. Health coverage has increased, but at whose cost has it increased? It's increased at the cost of households, not governments. So we are seeing that out-of-pocket is going up, despite the fact that coverage is going up. Out-of-pocket is going up. So we must worry because UHC is all about social justice and equity. So if we increase coverage but we don't decrease out-of-pocket, we are not achieving UHC at all. And as I like to say that, for us to achieve UHC, we need a good health system that addresses all the issue that we discuss here, but that is a just system. That's the addition to UHC. It's a health system plus social justice. That is UHC. So these are the challenges we are seeing, and the journey to there, especially when you have a low fiscal space. I don't know whether any of you were there today when Jeffrey Sachs was speaking, but also have written about this, that if you look at most of the low to middle-income countries, if you look at their GDP, you look at their tax efficiency, you look at their maximum allocation to health, even if they were to achieve 15% Abuja, you would be lucky to get above $30 to $50 per capita. But yet, countries that have achieved UHC, including UK, are spending $4,000 public money, not total health expenditure, public money. So how do you navigate this treasurer's journey with only $30 to $50 per capita? And the challenge to the NCD community is that we are not going to have an NCD health benefit package for UHC, an infectious disease health benefits package for UHC, a mental health benefits package. We are going to have one holistic health benefits package that's going to be within the constraints of the fiscal space. How do we ensure that we demonstrate that the gains that can be made by investing in NCDs within that health benefit package are actually going to give good returns?
If you can stay with us 1 minute longer, the gentleman sitting next to you is nodding along with this discussion because he's got a lot to say on this topic. I do want to quickly say who all of you are before I go to the gentleman sitting next to you. Just starting at the very end, Michael Oberreiter is here, the head of Global Access at Roche, our host. Thank you for having us. Dr. Mayra Kalefi, who's the chief of Breast Cancer Care Hospital in Moinhos de Vento and the president of FEMAMA, also a former board member of UICC. And let's see, Ambassador Sally Cole is here, the Senior Vice President of Global Cancer Control at the American Cancer Society. And finally, and the person I want to direct this question to, just to give a response to Gitanji Gitahi, is Dr. Dinesh Arora, who until very recently was the Deputy CEO of the Indian health system that just launched Modi Care, as it is commonly known.
Congratulations.
I was telling Dr. Arora that I was with the health minister of his country last year at UNGA, and he was telling me about Modi Care, and he told me the numbers, and I said, sorry, say that again? And then he told me the numbers. I said, I must be misunderstanding. It's 550 million people that this program is aiming to bring UHC and coverage to. So what is your reaction, Dinesh, to this discussion from Gitanji and this idea of how we fund and how we actually achieve it?
I just thought that 3 years back, I was in the same position asking for the same thing. Mm-hmm. When are we going to implement universal health coverage? And we had this in 2017, a national health policy, but the Prime Minister was very keen. Mr. Modi himself overseed this. And we had a predecessor scheme having about $150 per family as a health insurance scheme, social insurance. The Prime Minister said, no, it has to be a huge scheme which covers every disease, especially NCDs. So today we have a Modi Care, this is called as Ayushman Bharat. Today, in fact, in the Assembly also, General Assembly also, Prime Minister convinced and confirmed that we are on the path of UHCs. So the first round has been implemented. Today, in fact, we are celebrating first anniversary of Modi Care back home today.
We can applaud that.
And in 1 year, we have reached 10 million people. 100 million have been verified, 4.5 million have been treated, and of these, 3 million are cancer patients.
How much do they pay?
So this amount per family is $7,500. And in India, hospitalization episode, one episode costs $200. So this is huge. The predecessor scheme was only $500. This is $7,500. The scheme is portable across the country. I belong to one province, I go to second province, I fall sick there, I can take benefits. It's run on a common IT platform, which is seamless, paperless, cashless.
I'm sure many of you have heard of Aadhaar, which is the biometric identification system in India. It's based on that.
But $1,000 per family, yeah.
That's India?
Yeah, absolutely.
We have a whole room. Let's hear
So
it to all of us.
7,000
It sounds a lot for an Indian
You're impressed
family,
too.
7,000.
So $7,500 is, in India term, is 5 lakh rupees, which is perfect for a family. The initial amount which was given was 30,000. From 30,000, we have moved to 500,000. 17 times jump. And the biggest beneficiary here is, or perhaps the biggest attack which we were making was on cancer.
So, sorry, the $7,500 is actually the entitlement.
That's right.
Per family. That's
That is the
entitlement.
So when she was saying that,
But how much is the government paying per family?
so she was
Yes.
saying that when a person says, why should a poor person be only visiting a public hospital which lacks facilities?
Yeah.
Here is a scheme which is perhaps a model for the whole country. You put 5 lakhs or $7,500 in the wallet of the person and say choose any of the empaneled public or private hospital. Public hospitals have to compete for the claims now. The private hospital also has to compete. So it's qualitative. It's quality.
Okay, so you put
Put the
in their point system for them 7,000.
$500, go to any empaneled hospitals and get themselves treated.
Fantastic.
This is a public funded scheme.
Correct.
So government has linked it with the tax regimes. So as the GST goes higher, the money also comes inside. It's fully paid by the combined central and state governments.
GST
So we
is
pay
the
the
national
premium.
tax.
Yes.
So it's a publicly funded scheme.
My understanding is that the premium
Okay.
is a small amount of premium, which the government is paying from taxes, especially for 40% of the poor or whatever percentage.
so-
And so how much is that the government is paying back? Because the 7.5 entitlement is based on risk pooling.
That's right.
Yes.
Correct. So that 7.5 is based on risk pooling. But how much is the actual investment of the government from the taxes to say for each family
Yes.
covered, this is what the government is actually paying from tax?
Yeah.
What is that?
So that as much amount as we are spending per capita as of now. It's 1,100 rupees to begin with.
Uh-huh.
So 10,000 crore is the amount which is already put by the government to the National Health Authority to run the scheme for the first year.
Right.
First 2 years, 10,000 crores are already been put up. This scheme is a voluntary scheme for the states. We have 36 states and union territories, and today, the way the scheme is run, 33 states and union territories have joined the scheme. It's a 60-40 sharing between the government of India and the state governments, and we have a head start with about 4.5 million people already got treated and benefited. I will request each one of you, if you get time, to either go to the NHA website or I can coordinate a visit to India. India is changing. This is the new India. And this is what Modi Care has brought health and cancer in the forefront.
We will take him up on that offer.
Yes.
We're all coming. I know Sally wants to jump in quickly, please.
Well, what I want to say is how excited I am about this conversation, because I sit here as an American and many Americans in this audience. We've already heard from 3 outstanding representatives from 3 developing countries. I know there's another one who has a lot to say to my right.
Yep.
And what I'm saying is there are huge challenges, but people can't be ignored. That's number one. And number two, I think these countries and the schemes that they're coming up with are leapfrogging way over us. So just as M-Pesa leaps over sort of how do we do things by writing a check or taking out a credit card, no, we're plugging in numbers.
I can send you some money right now.
Yeah, thank you. I'll take it, and I'll take the trip to India too. But what I would like to say is this is where the innovation is going to come with, as you said. So maybe we had to throw it all out and sort of start over, because great challenges and great crises also create great opportunities. And I think that's where we are right now. So I'm thrilled to hear what I've already heard.
Yeah, I agree. And I want to hear the case of Brazil from Myra. Tell us more about what's happening now, what's similar, what's different, where does it stand?
Well, some people here might know, but Brazil has universal health coverage for the last 30 years or so. And really focus in communicable disease, infectious disease, and it seems like never came out of this, because when you talk about cancer, oh no, this is very highly complex, let's do another round, you know. And I think what I would like to bring about is that the power of civil society that really made the change in Brazil, because we're kind of asked not to step aside for a long time, and then everyone was sitting in one corner, like experts, professionals, business people, so private and public sector never talked. And now we are kind of having the feeling that the Minister of Health wants to talk to us, because we're saying, well, look at the numbers. We cannot afford anymore to face cancer as a highly complex issue, and we need to bring to as a primary care issue. Yeah. So then we have to change, to change the equation, because why, I wonder, in my sleepless night, why cancer became such a burden? Because we're only treating late disease.
Exactly.
Right. The numbers are rising and rising.
Rising and rising, and the technology is much more expensive every day, and people cannot afford it. The countries cannot afford it. What about if we start to think about the patient's journey? Like, where do they start having cancer? With symptoms, with signs, with some risk factors that hasn't been controlled, all right, for a long time. So let's go back to the primary care issue that never was an issue in cancer. So I'm not talking about specifically screening, okay, because people say in low and middle income, we can afford it. No, I'm not talking about screening. I'm talking about first signs of a disease that hasn't been, never is suspicious in the country level, in the countryside level, in the primary care level. It's only along the line, after months and months of this poor person going after something to get diagnosed, you know. So I think that sometimes I don't even know if I understood what you said about this, you know. I am a doctor, and what I can see is that patients go after healthcare for long months, for, you know, like too much, too far, and they are becoming incurable in the way. And we are providing them unaffordable care because they are so late.
In many parts of the world, they're going bankrupt. It's a major contributor to poverty.
But if you allow me to say something, I think the word for me today is integration. Because if you listen to what she said that governments in low and middle income countries say we can't afford to screen. But how many women come back with breast cancer who already have had children and have gone multiple times for antenatal care? But nobody ever did a breast examination. No one thought of doing a pap smear. I think that we are missing a big opportunity by not integrating NCDs into the health system. Because if I come in with pregnancy, there must be a protocol that says, if a woman comes in pregnant, you must do 1, 2, 3, because she is already there. So I think integration is a key word. And if we can integrate NCDs, including cancer, into the health system, with the Global Fund money that's on HIV, TB, and malaria, with the maternal health money which is there, because no one is giving money for NCDs. It's 2% of global health assistance for health. 2% is NCDs. The rest of it is maternal health, child health, and infectious disease. How can we layer that up so that any contact facility or even in the community has everything layered upon it? And now I have to go because I need nutrition. I'm going for a dinner, and I think take care of my nutrition. Thank you.
Thank you for being here.
Thank you very much.
Thank you. So, Michael, I think he was singing from your hymn book. Your job is to provide access. What do you think about this idea of integration?
So first of all, let me admit I feel pretty weak next to these fabulous people here with your stories. I think when I think about integration, so there's a lot of talking about universal health coverage and breaking down silos. And we talk about silos like they have existed like since forever. But actually silos were built.
Yeah.
And silos were built by humans. So if you want to break down silos and integrate things, you need to understand the human condition and understand what is the root cause why silos were built. And very often it's pretty simple. It is because I think I know better than you and I don't trust you. So it has to do something with overcome egos on both sides. It might be helpful to consider that not everyone who works in the public space is a saint, and not everyone who works in the private sector is the opposite of it. And starting actually dialogues and panels exactly like this. So integration, from my experience, starts with bringing people together and starting a dialogue.
Well, that was brilliantly diplomatic, and you left out the word politics, which is the other key point. You're absolutely right. Many of these verticals are pretty recent, actually, but there is a political element. There's a constituency that supports these things. You know, is there a constituency for primary care diagnostics and screening? Myra.
And I want to share something that I learned in my 6 days of being a board member at UICC, that we need to get cancer control in the agenda, right? Cancer control, people talk about it, but they don't think about it. So one of the really practical things that came out from those years, and you know, was the City Cancer Challenge. This is a project that we are developing along the way, writing up, you know, because it's very much tailored in the city, and we know that most of the problems are in cities, all right? So what really happened into the city that I'm living on is that people started to talk about it. They are not in silos anymore. And we open up the Pandora box of the public system. So the government is sitting with patients, groups of interest, pharma, private and public sector. This, we have to, along the methodology that has been very, very successful, I think, we are creating a new era of dialogue, of interest, and we're coming up with the solutions.
Can I, Sally, get your take on that? Because you're looking at the American Cancer Society kind of at a very broad level. And there are great examples like this one and some of the other ones we've heard today on the stage. But is this emblematic of what you see globally in low and middle income countries?
I think so. We talk about, you know, the silos that would be between communicable and non-communicable diseases, or between HIV is a silo and all the rest of them are silos. And those are important, but I think maybe the bigger silos have been between, you know, the government over here, the private sector here, and the civil society over here. Those are probably the longest built silos. And as Michael says, with a great deal of, if not animosity, at least distrust between them. We've recently been working in Kenya, among other places, and we've been working with across the spectrums, and we find that it's not in the City Cancer Challenge, but we have been working with a lot of civil society organizations to make them good civil society organizations, and to suggest they work with each other, but also recognizing that health is a jurisdiction of the public health sector. By and large, these organizations are not delivering cancer care or any other kind of care. But when you sort of break down those silos, and one of the ways we've broken it down is together, they and we and civil society organizations are building a patient lodging facility at the Kenyatta National Hospital. Hasn't existed, so somebody gets all the way to the only public hospital treating cancer, and they're sleeping on the grounds of the hospital. There's no place for them to stay. So they go back to their villages because it's too painful to consider, to go on with the treatment. So suddenly this is a public-private partnership, one of the first that's existed. And when people begin to work together, it does generate greater trust. And they're finding that it is possible to work together. We started a patient navigation program so that the patient has some idea of where to go and how to get services. The hospital then said, we should have one of these for all of our, not just in cancer, why don't we have one of these for the cardiology patients? So, a silo between cardiology and cancer is breaking down because they hear about some of these innovations.
I know Dinesh wants to jump in. I do want to give all of you a fair warning that I'm coming to you for questions in just a minute. And I hope you'll push us. Tell us what we're missing. Dinesh.
I think the point is very well taken. Hospitalization is failed medicine, actually, in a sense. It's a failed prevention. You don't want people to fall sick and then get them treated. The first point, the most important point, is to let them not fall sick. And that's what prevention is. So the choice is not this or that. It's choice. Even if you have full prevention, people will fall sick. If somebody has diabetic, they will have a diabetic foot, but you need treatment. If somebody has a cancer, they will go to metastasis. They may require oncology or a surgery. But the point is, the treatment is much better if you hold them earlier. So this is what under Ayushman Bharat, we have two pillars. One is what I talk about, the insurance scheme, and the second is building health and wellness centers. So we have about 150,000 coming across the country doing screening for cancers and NCDs. And the most important is the cervical cancer for the pap smear and the breast cancer for the woman. Wow. And so 37,000 cases were screened last year, which were found positive, of screening of about nearly 150 million people. They were screened. So it's very, very important. The point she touched was that it has to be both in conjunction. It's not this or that. It's not primary versus secondary or tertiary. It's not department versus department. Look, a surgeon who treats a patient, say a cardiologist a cardiac surgeon who treats a patient, he tells the patient, now take less cholesterol, do some exercise. Is he not doing prevention? It's we humans who have broken down into primary, secondary, and tertiary. It's basically a human life being taken, and what is the best recourse? The best recourse is do not fall sick. If you fall sick, get hold of them earlier. If he gets sick, get him a good quality treatment so that he doesn't reach the last stage. If he gets into the last stage, give him a good palliative, rehabilitative care.
I am sold listening to you, but I know it's not that easy. I know it's not that easy. Right. So I want to get into the challenges in a moment, but are there anyone here who feels like they want to jump into the conversation at this point? I know we have a lot of expertise in the room. I see a hand here. Anyone else? And in the back? Okay, and also there. We'll take three at once. So right here in this row. And just tell us your name and if you're affiliated with any organization, please.
Okay. My name is Beatrice Gachumia. I work for Amref Enterprises, which is a social impact business, as a UHC lead. And one of the things we're grappling with is exactly what you said, palliative care, because it often is left out of the cancer conversation. So what kind of models do you envision would enable, palliative care to be delivered? Given, of course, we are talking about often households that are impoverished already. So putting patients in institutions is not an option. So what models can we think through?
Thank you so much. And then we'll take a question all the way there in the back.
Bistra Zhelova, Children's Heart Link. I have specifically two questions for Dr. Arora and, Dr. Kalefi. How do you ensure that the care that's provided is high quality? Because I think that's one of the big issues that we're facing, especially in non-communicable diseases. And I've actually been to your hospital. It's beautiful. And I work in India, and I know that's a big issue between private and public sector, that we can't assure quality for the same patients.
Well, you've been to both of these places. Perfect question for these two. Back here, if we can get the mic all the way over there.
Hi, my name is Mara McCarthy, and I work at JPIGO, which is Johns Hopkins International NGO. And recognizing that we have many peer organization and partners here in the room, I guess this question is for the whole panel on increasing political will And how do we do that, particularly for programs like breast cancer that may have a primary care link, and that's something that JPIGO is working hard to do, particularly in breast, is to decentralize diagnostics and empower district hospitals to do things that the tertiary facilities generally do. But from a funding perspective, this is really challenging. And so how do we think about, how do we increase political will for programs like breast cancer specifically and other cancers that don't lend as well as cervical cancer into larger HIV infectious disease platforms?
Okay, thank you for that. And I know there's others who want to ask questions. We're going to come back around in a moment, but let's start with this. Dina, please.
Yes. I think in answer to one of the questions, that's what UHC is about.
Are you talking about the palliative care?
No, yeah, we're no more thinking about specific diseases. We're throwing everything that we sort of inherited or organically inherited, and it became the way it is. And the whole idea is to transform it. It's really like a very logical business. If you had let's say a company that sells products, right? You know, when we go to that product, let's say to that shop, or you go to a supermarket, for example, they make sure we are the target audience, we're the target customer. All the way through, they are making sure we are looking at all their products down to when we reach to pay money, right? They put chewing gum, they put things, they are making sure to maximize our stay at that supermarket as much as we can, right? And it's the business model that somehow we didn't apply into health systems. It's really exactly what our colleague here has said, is UHC is looking with a fresh view. We're not saying adding or another band-aid solution, looking again at humans as one solid human being, not in body parts, not in specific diseases, and thinking again, okay, I've got this target customer that is costing me money, right? It's like any manufacturing operations. It's really process engineering. This customer is exposed to all these risk factors. This customer comes to my primary health service, and I don't want him to cost me more when he goes down the line. What can I do to make sure that I capture this customer by giving him all the preventative, the primary care, the information they need, etc., and down the line, and so on and so forth. So really, UHC, that's the thing about UHC, and I would really love you to say, how did you have a transformation team? It's the how that nobody has spoken about. Yeah. Is it that, are you involved? Did your Prime Minister Modi says, look, go away, you with top experts, look at different models all over the world, think about redesigning the processes. How we need to hear about that.
Give us the backstory.
Right. So this, we have been talking, the Prime Minister came into power in 2014, and he was talking about how do we curtail catastrophic expenses? How do we make sure that people don't fall below the poverty line because of health expenses? And it took us nearly 3 years to come to this scheme. And it was Ministry of Health, Niti Aayog, that's the planning commission.
So there's a planning commission. No countries have that. That's the thing. They need to know this is serious.
It's called NITI, National Institute for Transforming India.
Oh, thank you.
And even when we came up with this vision, Prime Minister doubled it.
Yes.
We said 2 lakhs, he said no, 5 lakhs.
Yes.
He said this is what I want. I think the more important is we need to break it into the forefront of political will. Fortunately, we had a Prime Minister who was more than willing to walk the talk.
Yes.
When he came up with the national health policy in 2017, he says the next has to be the scheme. Now, I need to see the results.
But Dinesh, our colleague from JPIGO's question about political will, do we just wait for we happen to have the right Prime Minister at the right moment, or what can we as a global health community do to drive this?
So I must admit that for India also it has taken 70 years of independence to come to this.
Yeah. No,
So
that's depressing. Don't say that.
So this is This is what I'm saying is we need to create a policy window.
Yes.
We need to tell them. For example, many of people were thinking that NCD is a disease of rich.
Yes.
It's not for the poor. Unless we show them the data that this is happening across and poor are not getting identified. In fact, the unmet need is the highest in the poor. I think one thing which goes into the political will is data. Go with an evidence and data. You will get an elevator pitch of 5 minutes with the Prime Minister, but tell him what is happening in the field. And they are aware, and they are much more better, much more sensible than us. They have more the pulse. It's more of communicating them, but I sincerely believe data is something which you should go with. This is something happening there. This is the and this
Scientific
is the
approach.
scientific approach.
What is your take on this, Michael? Because this is, I think, from the
In fact,
corporate
I must
sector.
admit also that Roche has been an important partner with us, especially when we are establishing cancer cell in India, and they were helping, giving us technical support. In fact, one of their staff members was working with us as a volunteer to help us in setting NHA. Thank you, Michael, for that.
I had nothing to do, but thank you. I give it back. So political will. I think it's coming back again. You need to understand what's going on in the brain of a politician. What we did in the past is you go to the health minister. You make your case. Even if you have data, then you speak only to the health minister. Lovely. But that's not the guy with the budget or the lady with the budget. It's the finance minister. So it's about how can you shift the perception that if you invest in healthcare, it's purely cost. Because in the political accountant logic, healthcare is cost. Very few countries see it actually as an opportunity that healthcare is actually one of the key investment drivers for the economy as well. And actually we do have in the history of medical interventions, there's a pretty good example where we, and I mean not the industry altogether, managed to shift the perception from cost to investment. Vaccines. If you look 50 years back, healthcare systems, and as you said, healthcare systems that they were not designed to keep people healthy. They were designed to take care of sick people. So nobody ever invested in prevention. So when the first vaccines after the measles came in, they had HPV vaccines, pneumococcal vaccines around that. The way they could convince policymakers was that you really did what we call internally like a business case. So you looked at if you invest now, what is the return on investment of society? You have to collecting the data. You have to show who is affected. And specifically in cancer, yes, maybe one person in the family gets cancer, but the whole family, the whole ecosystem of the family is affected. So we have also to become better in the narrative and using the data to make the case, but also speak to different stakeholders, not only to the Minister of Health.
We actually have an op-ed on DevX from Seth Berkley, the head of Gavi, on making the case for vaccines as a prevention measure around cancer, because so many cancers come from infectious sources, and he does it in a very economic argument that the vaccine community is very used to making. I know many of you want to jump into this conversation. Myra first, please.
Was interesting, thank you for the question, but we're not talking about a private sector hospital, right? That is a very nice one, but we're talking about the whole city or the whole state, the whole country. And I think that really, that we never had such an opportunity to use technology to help us to equate this problem. Because if we're going to do as we have been doing in the past, we're not going to make it.
Right.
Sorry. We need new stuff. Artificial intelligence, data. We need softwares. Maybe everyone is on WhatsApp and has a telephone, even in the most remote area in Brazil, in the Amazon. They still. So we need to bring partners from technology, from pharma, and see how is cost effective. This is the planning again. Is this worth going? Is not. So I think we need to reinvent ourselves to tackle this problem. And I really believe that there is one thing that Brazil is moving forward nowadays, taking the example of AIDS and other areas, malaria and others. We need cancer notification, mandatorily. When we have a cancer patient diagnosed, cancer person diagnosed, we need to have to go through the system, and we have to be able to follow this person and not to get lost, because this is again is timing and resources. So I think again, technology will help in this case.
And I'm so glad you brought that up, because of course the world is not standing still, And if we meet next year and have this conversation, or the year after that, the number of wearable devices, the level of connectivity, the number of smartphones, it's exploding. And consumers are voting with their feet, and they're going out and buying these products and using these products.
And they have cancer as well.
Yeah.
Exactly. Now, I know all of you want to jump in. I think Dina, Sally, okay.
Yeah, I mean, it just strikes me hearing this conversation that in some ways, and back to the political will question, I mean, in many ways, cancer is the 800-pound gorilla in the room. There is no country that can ignore it now. I mean, if we have 18 million new cases of cancer in 2018, that will go up to 10 million additional new cases a year. 10 million, that's an amazing number by 2040. That, in a sense, creates a huge amount of political pressure. And at the same time, if we look back on the HIV era, maybe 20 years ago, the world has progressed a long way toward becoming more democratic, with people either voting with their feet or voting. So I think there's going to be enormous pressure, and I think we need to couple that, A, with smarter ways of looking at it, and B, with data that shows that there really is a return on investment that a government can understand for investing in, certainly in cancer prevention, but also in cancer treatment and care. And that investment case is there and can be made. And I think also the big data will help countries around the world who have cancer plans to have a better idea of what their needs will be for specific therapeutic drugs, shall we say, or the amount of radiation facilities they will need, or radiotherapy facilities. And that in turn will allow better planning all along the spectrum, which will allow the private sector to respond in more coherent ways to the demand that they know is there. I mean, look at an example that sort of failed, and you brought up HPV vaccination. When it was launched like 12 years ago, Merck and GSK, they all stepped up their facilities to meet what they thought would be the demand. But there was no demand, because either nobody knew about it, or there was a great pushback on HPV as sexually transmitted disease and so on. So the companies that were in it went away. They had to use those facilities for something else. So now all of a sudden there is that demand and there's not enough supply. So, I mean, somehow we have to have this conversation in a way that it's empowered by passion, but it's supplied and managed by numbers.
Okay, what I'm taking out from those comments, just to the question about quality in the back, is you need strategic planning and innovation, and that's how you unlock the quality question. Dinesh, you wanted to add something, and Dina too, sorry.
Answer the question on quality she had asked for. I think what is important is the incentives should be aligned properly. We in 2011 passed the Clinical Establishment Act regulating private hospitals, but failed. It couldn't do properly the quality regulation. Now what we have said in our Ayushman Bharat, if you are bronze, gold and platinum, you get 5, 10, 15% extra reimbursements. Move on a quality ladder, move on an accreditation, and we support you more. And that's giving results.
People
So I think
understand that.
incentives alignment is very important. That will help in quality.
And actually, just to confirm what you said, in Turkey, that's what they did. And this idea, but that's another thing, is between UHC doesn't mean you ignore the private sector. The fact that you give money to the family to go where the quality is, to give them the is an acknowledgement. It doesn't have to be either or. But I wanted to answer your question about how do you get a politician to take notice. And one of the main really engines for that is the fantastic initiative of City Cancer Challenge that we as UICC were very proud to have initiated that, and now it's a standalone foundation, and Sue Henschel is there, the CEO, and we've got our past president Sanchia now becoming president. That model brings NGOs, oncologists, everybody who's an influencer or even a disruptor on the same table. So in a way, it creates the infrastructure on the ground whereby there's enough voice from everybody on the table, the technical, the NGOs, the mayor, the ministers and so on, not just the health minister, the lonely guy on his own trying to do stuff. And they take them through the process. Again, we go back to a scientific process. How to, first of all, there is a lot of work. That's the thing. Look, 3 years it took them just to plan. That's that's what people really need to understand. You need really good planning to find efficiencies. And that's what the engine does. It takes them through the whole process of finding the gaps, then having priorities, action plan, and so on and so forth. And the beauty of it, it makes them to work on one plan.
Yeah.
And that engine, which is the City Cancer Challenge, what's so special about it, it's really like, it's also long term. It's not like you're having some experts coming in. They come and give you their wise notes and up they go. They stay with you for long term to, and walk your walk as well to see how it is. And I saw that personally. I saw it in Asuncion. When we first went to, the program was still with UICC, and they said, let's go to, the program wasn't really jump-starting very well. And so we went there and with the team and met the Senate, met the president, they heard about it, but they were not quite understanding, is this yet another thing from global health community coming to tell us what to do? Not yet. So we, at that time, when I met the Senate, we found out that there is a cancer law that was about to be approved at the, in the parliament. And then I asked, haven't you had did you show it to the new executive city team, which has everybody sitting on the table? They said no. So somehow with the conversation, we said, for God's sake, don't do that. Give it to the city executive. Let them have a look. This year, so early this year, we found out that not only the city executive team, they really edited it and changed things, added things exactly as to the country's needs. And for the first time in the history of Asuncion, the government put 50 million. So again, like I think what I was discussing with Myra, I said, you were an oncologist doing, and really a big advocate for cancer all these years. What was it for you in Porto Alegre? Remember when we were speaking in the other room? She said, we felt we're closer to the decision maker. Myra, as an oncologist, when is she going to get an appointment with the health minister or the president and so on? So this engine really prepares that political structure for it to be taken notice. So if you don't have the political will, that engine helps you be noticed as well.
And it's free consultants for them.
Yeah.
Yes.
We are volunteer in this, and we want them to be helped to help the people. And I think once they realize that, and they will be more kind of successful in their run, because you have to give them some, pedestal kind of. Right?
And it's a challenge in the way you, Dinesh, were talking about gold, silver, bronze. It's an incentive because you've got to apply, and only the ones who've got the best proposal can win. And that challenge also moves people. I know we have a few other people want to jump in the wow, a lot.
Wow.
We're going to take 4 this time. And we can start up here in the front row. This gentleman's been waiting. You here, and then all the way over there. And again, if you can keep them relatively brief given the amount of interest in being part of the discussion, just tell us your name and your organization. Right over here, please.
Hi, I'm Andrew Schroeder from Direct Relief. I wanted to ask you a question about technology and costs and rights. I think there's great examples that you've pointed out around technology as a driver of cost improvement. Often, though, especially among drug therapies and new treatments in cancer, it's exactly the opposite, actually, that cost is going dramatically higher. And that's actually very effective for the people that have access to it, but that creates a significant access burden. So where you have personalized genetic therapies that are upwards of 70, 100,000 more per patient per year, but are demonstrably effective. How does that fit into the rights framework that then allows for that to be extended to the kinds of populations that you're talking about?
Okay, thank you for that question. We're going to pass the mic around. Sorry, back here. We'll come around later on. Back here. Yep. You can bring the mic there, 3rd row. Yep.
Thank you. Lucia Cordon with Raven Martin. I think It's been very encouraging to hear the conversation focus on political will and the importance of national cancer planning and long-term planning. But one area that we haven't talked about very much is the immense promise that there is in innovation in cancer, in the cancer space right now. And I think we're seeing clinical results that were unimaginable years ago. And so, and particularly in the space of targeted therapies and being able to get the right therapy to the right patient at the right time. And so I wonder, as Princess Dina was talking about before in terms of efficiencies and thinking about where to invest and what makes the most sense in building the business case, how we think about this innovation in the future of cancer planning.
Thank you. And in some ways related to the first question, we'll take the mic over here if we can get it.
Hi, thanks. A great panel. Rebecca Kohler from IntraHealth International, and we're an NGO focusing on the health workforce. And so my question is a lot of conversation about sort of the higher level about the planning, but one of the things that I wonder about, there's only one mention of an oncologist, and that's only one of the healthcare team needed for cancer. And there's a lot of talk about innovation. It ends up being about innovation in technology. And I guess I'm interested to know where some of the innovations are and how you use care teams to really drive more efficient care and definitely more respectful and just care.
Great, thank you. And then right over here.
Thank you. Stephen Jan from the George Institute for Global Health in Sydney. My question's to Dr. Aurora. I just want to ask about the funding requirements for Modicare. I mean, currently, you're saying that the funding need for Modicare is going to be per family 17-fold more than what they're currently getting. Currently, the government of India, in terms of public expenditure on health, is about 1% of GDP. What level does it have to go up to in order to meet the full demand of Modicare when it gets fully scaled up? And is that going to be politically feasible?
So that's a very straightforward question. So why don't we start with that one quickly, Dinesh?
Right,
what's the number? Where does it have to go to?
Yeah. So we have already committed that by 2025, the funding will go to 2.5%. And mind you, 1.08 is what it stands right now, 1.18% of GDP, but the GDP has grown 10% every year in the last 10 years. So the actual amount has grown up, but I agree, percentage of GDP spending has to go up. So the Prime Minister has committed, the government has committed in the National Health Policy, by 2025 it will go up to 2.5%. I'm sure this is going to happen.
So maybe we can take on the question around these gene therapies, the cost, the innovation opportunity. How do you see this in the conversation? Because it's true, we haven't really talked much about the promise and what the latest tech is.
So I think for years we're talking about affordability as an issue. I like to be very blunt, affordability is a problem. It's increasingly a problem. It's not only in low and middle income countries, it's literally in every single healthcare system around the world. It's a problem just because the way those where you have a healthcare system, they are mostly based on like a Bismarck or beverage system from 200 years ago, right? So the tax is coming from literally human labor, so they are consistently underfunded. Industry response is, and this is actually also the beauty of UHC and the contribution of City Cancer Challenge, is that this whole discussion will lead, and we see it already, not only in Roche, also in other companies, that we need to transform and further evolve our business model. And in very concrete terms, if you ask me, like, how can I make a gene therapy at the same time available, like in Europe and in Africa and in Asia, my answer right now is I can't. But we are aware of the problem, and we are working together with local stakeholders. What we did very concretely is, and I think again, this is the beauty, UHC has changed the tone of the conversation you have within the company. 10 years ago, I mean, Access like literally forever. So Access there was a pricing guy, there was an HTA guy. If you look at my team now, I have people who work in the capacity space. Not a single day they're thinking about products. They are thinking about funding streams, they're thinking about private healthcare, they're thinking about issuing government bonds, they're working with AXA industry all around that. So this was also really this is the benefit of UHC when it comes to the pharmaceutical business model. And we're seeing now that we have a variety of models. So we have a drug in our portfolio for hemophilia. And what we did is we looked at the you're nodding, glad that you're aware of it. So we looked at the data and we found out, obviously, India is really an epidemic hotspot. So we came up with a completely different business model. So there is a price for this drug in like those countries who have a budget, which is significantly higher than the price we're offering in India. But we're still facing the challenge of the diagnosis, we're still facing the challenges, where can patients go? We still face challenges of infrastructure. So I think we have started not shying away from the discussion, but I'm afraid right now I can't give you a straightforward and answer. Right now we're looking at it really from disease area to disease area and developing kind of targeted solutions when it comes to pricing.
Another challenge that was brought up is around workforce. And it's true, we really haven't talked workforce much. You're maybe closest to this in some ways. I see Sally raising your hand too. Let's hear from both of you, please.
Yeah, I just wanted to go back to one thing that and addresses this question of our inequity, that what is more becomes more and more inequity when the disease is getting later and later. Okay, for the essential list from WHO really brings treats most of the cases of cancer at the beginning. But when you get later stage, they are not in the list anymore. And where most of the innovation comes, right? What I think that for an oncology point of view, when you are in front of one of your patients is one thing. When you need to establish like a protocol for your city, for your country, is another thing. One of the things that really bankrupts the care in Brazil was the possibility of people that had higher voice or could hire lawyers get better treatment than the rest of it. This is horrible. The judges are the ones to decide who is getting the medicine or not, because it is a right for the patients to sue the government, for example. This is if we can get all this money into care, is enough to fund most of the treatment nowadays. So this is something that we are dealing in our environment. We have to change the way people think, because we cannot really treat some and not treating the most of it. And the second thing that I wanted to say is that in this country, and as an oncology, I know that 40% of the patients with cancer are treated under clinical trials. But this doesn't happen in our countries, in the low and middle income countries, because we don't have the standards for it. So we have to pay from our pocket to this innovation. So what about if the clever guys from the high income countries will teach the low and middle income countries to do clinical trials and get help for our care? I don't know if I could get across. I think it's the very countries that they are more wealthy, they are the ones that do clinical trials by the industry, not us. Right. We have to pay out for our pocket, and we don't have money enough. So the clinical trials will come into the question. Another thing is like having protocols, because we know nowadays that is a very easy technology that's one call away, saves more people than any trials anywhere. Okay, so this is just the patient can call to somebody to get help. This is how we make your workforce to be able to do that. You know, and probably go back and educate your professionals, go back and educate even your patients that we are not doing very well.
I want to get others in the conversation, and our clock is starting to wind down toward the end here, so this will be maybe your final thoughts. But Sally, what's your take?
Well, just very quickly, because this is an important discussion, but again, it strikes me that there are some precedents in if we look back at HIV, both in terms of innovation, drugs, and workforces. And, you know, I think what's possible soon becomes imperative. And certainly when the first antiretrovirals came out, you know, there was great euphoria among and then great despair when it was realized that, you know, these were only going to be available for a very small subset. And we've seen, of course, prices come down incredibly. We've been working very hard with CHAI on some access to cancer drugs with a number of companies and hoping to expand those agreements to include others like our hosts here, Roche, because I think there's room for some movement in return for working with the industry in ways that the industry finds compatible with its own business model. So I don't think we should just give up and say it's all too expensive and it will never happen. It will become necessary and it will happen, and it'll happen faster than we think. On the healthcare thing, again, two lessons from AIDS were the sort of task sharing and task shifting. And you've talked about that a little bit, and moving cancer down into the primary health systems. That's going to happen too. Everybody can't line up at the King Hussein Cancer Center or the Tata Memorial Hospital or Mona's Hospital. It just won't happen. So we're going to have to teach people who now think of their role as being more circumscribed to do more than they ever thought they could, because the situation demands it. And by and large, I think the profession will rise to meet that. We'll be covering these needs by breaking down the silos that have existed within the healthcare workforce.
Dinesh, a final thought from your side?
Well, just to, I'm glad you said Tata Memorial Hospital. They are our partners in the cancer cell in NHA. They provide us the technical support. It's not about purely money, it's about vision. It's about setting a priority. You know, say a person is never busy, it's only about priorities. I think cancer is a priority today. It kills more people than anybody else. And people initially used to believe that it's an individual disease. Like if you have something from a cholera or something from a diarrhea, it's a community disease. But they used to believe cancer is an individual disease. But when so many people die, it can't be individual disease. The risk factors are common, and that's what has changed in India is it has been brought into as a public health disease, and that's what has helped us. Second, it's about technology use. Let's use technology to the hilt, especially based on data. Data brings evidence, and evidence leads to good decision making. Whatever is measurable is only performed in the field. If I can't measure anything, I don't believe it's happening in the field. And I need data which is qualitative, not about so many screenings done, 2,000 this done. It has to be actual with their ID numbers, so that I can see their PHR, personal health record, which is transferable across the thing. I think you must see the system which we have built up. Huge scope for improvement, but very good to start with. And finally, I think workforce is a challenge. If what is hampering us is also the quality of manpower, and perhaps required number of field force for this. That is a challenge which will always remain, I think, for some time, because it's a huge issue has happened. Cancer is an epidemic, and it's a pandemic because it's across continents. Only the types changes, and it's criminal to have a cervical cancer if it is caused by human papilloma virus where vaccine is available. I think each one of us are to be blamed if somebody gets a cervical cancer which is preventable. A cancer which is preventable should have never been able to happen, and it's happening in huge numbers. So I think it's about priority, about vision, and less about money.
Thank you for that message. I want to end with Dina, but before I go to you, I do want to ask Michael, as our host, for a final word. And in particular, I wonder if you could say something about the role of the private sector, what you want people to understand about that role and how it's evolving.
Can I make one comment to the health worker? Because my mom is a nurse and my two sisters are, and they're gonna kill me if I'm not. Also, I think one of the problems, and it starts with Europe, for example, is they are chronically underpaid. So they work horrible hours and they are super lousy paid. So what you see is, what is the issue, for example, like in the Philippines? Like all the nurses from the Philippines get high quality education. So the nurse education in the Philippines is outstandingly good. It's at least as good as in Europe. But of course they're going to Europe because there's labor migration. So I think we have to tackle it almost like from a global perspective. And I mean, will not sort of immediately have an effect, but like we have to raise the wages for those people who work like in that incredibly challenging space. Otherwise, we will not attract new people, and those we have, they're gonna go to the rich countries. This is what's happening those days. Sorry, I forgot your question. I was like,
well, I wanted to give you a chance to talk about the private sector role and what you want people to understand about how it's evolving and where it's going and what you need as, you know, from the broader global health community.
So I think I need an invitation. I simply want to have a seat on the table. Once I'm on the table, feel free to challenge me, right? Feel free to, but invite me or invite us to the table. As simple as that.
Thank you.
And I just want to add that we need to empower patients. Always. Okay? They are the ones. This is why we're here for.
Yeah.
We cannot forget how much this is important, because they can make really things worth it for any kind of insurance or leader. I think this is something that we have to put more effort in advocacy and patients' capacity building.
Thank you. And I do want to say, Dina, just before you speak, that I was listening to Dinesh. I agree with you totally. It is not just about money. It is about vision. And I can't think of a leader for this community that would be better than you, Dina, given the vision you have brought forward tonight.
Pressure.
Thank you so much for what you have done, the leadership you brought. Give us your final thoughts to close this out.
Yeah, I just want to actually, first of all, really, you asked about the an example of a really good public-private partnership, and really it would be Access Accelerated. And really thank you, Roche, for being a part of that, and all the other pharmaceuticals. And what's really fantastic about that model is the fact that you all decided to leave out your logos aside, highly competitive industry, and to join as one big force. And also you had the vision to really, in a way, put the UHC model without you before it happened. You have it, because you've joined a multi-sectorial engine on the ground. So you were ready to work with others, sit on the table, and you were invited also on the table, and really, you know, you were the first donation to that program that helped jumpstart that engine to start working. And I would love for other industries such as, medical equipment and others to also join forces in a similar way, but also to join, like, what I like about that is that you really understood that you are joining a scientific approach. That's the thing. I go back to what Dinesh is saying. It's all about money is there. Money is there. It's about planning, prioritizing. I remember one lady, first lady came from some country in Africa. I'm not going to mention the name. And she came to the King Hussein Cancer Foundation, and she was saying she wants to talk about making houses, building infrastructure of, these Ronald McDonald's houses. Mm-hmm. Lots of money, showing us plans. When they had so much cervical cancer, again, good intentions can only lead you so far. You need the business approach, the logical approach. What's my priority? She would have said She would have gotten the money from, having started vaccination in her country or early screening rather than building those, big infrastructure with big designs and so on and so forth. It's all about UHC, it's all about comprehensive planning that looks at the healthcare workforce, the lack of that. It looks at all the elements properly. And look, I remind everybody again, it took 3 years by a special planning commission. In Turkey, it was the transformation team. In Thailand, it was called the policy entrepreneurs. These people, that's all, I suppose that's all you did. You woke up every day with that team and designing and looking at processes. A health minister and his team cannot do that. They're busy with operations. And of course, you need smart people like me.
That doesn't hurt.
Thank you.
Ladies and gentlemen, please join me in thanking Her Royal Highness Princess Dina Mered. This whole panel, a fabulous panel. Thank you. And join me in thanking Roche, Weber Shandwick for putting this event on, and all of you for great questions and energy. I wish we would have gotten to all of them, but I think there's a reception, so maybe you can get them in then. Thank you.
I think we should invite